Good morning, good afternoon, and good evening. Welcome. My name is Benedict Walter from the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Welcome to today's webinar. It's the third one we organize in a series on engaging the private sector for quality of care, and this series is organized by the Network for Improving Quality of Care for MNCH, as well as the World Health Organization. The purpose is to share lessons of successful engagement of private sector for quality of care in the network countries, but also to give a chance to hear the private sector perspective in this process and what they stand to gain in investing in quality of care. Today, we will hear from a program in India called Manyata, which is a certification program designed to strengthen quality of maternal health service in private facilities. Manyata has been rolled out in 6 states in the country already and is implemented by JIPIGO and a consortium of partners. We will have 3 sections today to this webinar. It's a bit of a different format. The first part is a broad introduction to Manyata by Nuranjin Prasad, the Manyata manager and associate director in JIPIGO. The second part is a panel discussion where we will give you different perspectives from different partners in the endeavour. And we are lucky to have Dr. Archana Patil from the Government of Maharashtra, who will give a perspective, Dr. Bulbul Sood from JIPIGO, country director in India, and Dr. Nandina Pachetka from Foxy. This will be moderated by Ms. Pompi Sridhar, who is director in India for MSD for Mothers. And then finally, the third part will be our usual question and answers, where we'll have 20 minutes where the speakers on the panel will be able to answer and give comments to your questions. So please, what we ask you to do during part 1, the presentation, and during part 2, the panel discussion, do type your question in the chat box at the bottom right corner of your screen, so we can then curate your question, direct them to the speakers, and they have some time to answer them. Don't hesitate, we do have 20 minutes for the Q&A, and we really want to know what this audience thinks of this program and how your comments about it. We'll record this session. We also send you a link tomorrow with the recording and the presentation and all the other material we're using today. And we are also broadcasting live on YouTube. I am now handing over to Suranjin Prasad for the introduction to Manyata program. Suranjin, please.
Quality of care for MNH services in the private sector. My talk will largely be divided into 2 parts: why we want the program, what did we do, and how we achieve this. We know that over 66% of deaths in India are due to poor quality of care. And just by ensuring better quality of care at childbirth, one can significantly improve maternal and newborn survival. We also know that 60 to 90% of deliveries in India are within institutions. But even though they were within institutions, they did not translate to a proportionate decline in mortality. And quality in these institutions was key to reduction in maternal and neonatal mortality and morbidity. Out of these high institutional births that were taking place, anywhere between 30 to 50% of births were taking place within the private sector. India has a very robust mixed economy and a private sector market. But the private sector, though large, is very diverse and fragmented. Quality within these private sectors was suboptimal, and there was no focused efforts in improving quality of maternity care in these places. And that was the gap that with Foxy, JIPIGO, and MSD from others decided to fill. And we said, how can we work with the private sector to incentivize their need to ensure quality and therefore, have a reduction in maternal mortality and morbidity. We centered around the delivery period, that's the intra and the immediate postpartum period. Our framework largely, resembled the quality maternal and newborn care framework, that was prepared by the Lancet series. We were largely focusing on first line of management for complications, both for medical obstetrics and neonatal services, promoting normal delivery, promotion of assessment and education. We looked at workforce, we looked at adequate resources should be available, we looked at a system approach, and we also added in components for respectful maternity care. Manyata program was branded as a seal of quality that an institution would get and would be known for quality in the community. We created a certification program where hospitals and institutions that provided maternal care would be certified through a process that I'll explain later. But not only a certification process, we also worked on a quality improvement process. We actually worked on sitting together with hospitals, both big and small, both small towns and in large cities, and help them to come up to a level we would be able to certify them for quality. And most importantly, we try to create a community of practitioners that would strive for quality and continuously improve and take this further. So that Manyata program is a real living program. We've been targeting to reach at least 2,000 facilities by the end of 2021. We have so far registered 1,154 facilities across 6 states in India and certified 818 facilities. And at this moment, in over 327 facilities, our staff are actively working with hospitals in improving their quality and taking them forward. The first thing that we worked on was modifying the standards for practices. We created 16 standards for the clinical practices with FOXI and 10 standards for facility systems in close collaboration with the Government of Maharashtra. Once these standards were codified, we helped look at the clinical competencies and skills that these products required. And we packaged them so that these we could use them in trainings. And initially, the trainings were mostly on-site and off-site, but we slowly moved into online trainings. The trainings were a mixture of skills and drills, and they were layered with a constant respect and dignity, which was inbuilt in each of these training programs. We also went on to mentoring these facilities for change, building up systems in this facilities by helping them with checklists for inventory management, for clinical protocols, for better case records and documentations, and we helped institutionalize quality circles within these hospitals. And this is what we did within the hospitals. For certification, FOXI came up with this mechanism of peer certification, where peers from another district would come in and certify your hospital. And now with online certifications happening during the COVID era, we've got one state assessing the other state. In Maharashtra, we've been working with the Government of Maharashtra, where there's a joint certification system where both the government and peers from within FOXI have certified the program. We've also created a digital backbone for this certification process. And on this digital backbone, facilities are continuously encouraged to submit their standards quarterly, even after they've been certified. The most challenging part at this moment is how do we get a total market approach for quality? Once we made these systems in place, how do we take this to the market and see that the market sustains this? Who would do the QI? And we've got some interesting learnings here. And one of the things that we're moving is with champions, because we realized that it just can't be plain business establishments, the drive for quality that mattered. How would QI be delivered? So we came up with packages and care bundles, we leverage digital technology to take this through. The most important question was who would pay for this QI? If people had to pay for it, what would be the amount they would be willing to pay? And what would be the value that we would be giving to them, and how would we incentivize this? We try to work with meta-regulation of quality with the Government of Maharashtra and bring in the governments to incentivize the private sector to adhere to quality. And these are some things we've tried to take it forward. We've got a rich set of learnings that we will be sharing on a continuous basis after this. Ariadne Labs is with us to take this through. And just a brief glimpse of what we have achieved in Manyata in the last 2 years of our work here. One thing what we notice is the facilities that join us always report that they've started doing better. We've seen a 27% increase in footfalls within these hospitals that are joining. The most important thing that we really are looking at is better quality of care. Important clinical practices have improved, either the use of partograph, the use of ultrasonics, the use of the safe childbirth checklist, and important maternal and neonatal clinical protocols have come in place. Complications. What we've seen is because these hospitals have actually started adhering to evidence-based practices, we've seen a 40% reduction in complications within these hospitals. And we've also been documenting a steady decline in the stillbirth rate within these hospitals that we are working in. We're going through a very exciting journey, and with us, we have a large number of partners that have come together to make this possible. And without all of us here, this whole Manyata journey would not be possible. We'll soon be hearing from our experts and our stalwarts on the little nuances that were needed to take this project forward. Thank you.
Thank you very much, Suranjin Prasad. I'm handing over to Pompey. Pompey, if you can unmute yourself so we can hear from the panelists. And I'm going to share here a slide with the name and affiliation of the panelists so you know who is on the call and on the panel today. Pompey, please.
Thank you, Benedict, and thank you, Suranjin, for the wonderful presentation. My name is Pompey Sridhar. I'm the Country Director of MSD for Mothers India. And I would really like to begin by thanking all of you for taking out time to be present here today. And more than that, I really want to convey heartfelt thanks to making this program, Manyata, a global largest maternal health quality improvement program. And I would really compliment Government of India, Government of Maharashtra for taking the lead in showing how a public-private partnership can ensure standardized care is accessible to every woman. So I would like to really welcome Dr. Archana Patil, who has been at the forefront of this public-private partnership. As you all know, Government of India has launched a program called LaQshya, which is essentially an umbrella program under which all quality improvement programs related to maternal health have been brought in with a single agenda of ensuring standardized quality across all public health facilities in India. And it was Government of Maharashtra who came up, and when they saw our program, which then had about 500 facilities improving quality in Maharashtra, suggest about a partnership so that all women in the state of Maharashtra can get quality care. So I would like to ask Dr. Archana Patil to tell us about why did government feel that it was important to engage with the private sector to improve quality in the private sector hospitals. Dr. Patil, please.
Yeah, good afternoon, everybody. It's a great pleasure for me to be a part of this webinar. As already you have mentioned that the Government of India has started the LaQshya program 2 years back, and the Maharashtra state is one of the best performing state at the national level. So when we analyze our data for the institutional deliveries, it is found that about 45% deliveries in state of Maharashtra, they take place in the private sector. usually what happens that the various quality programs, they are started in the government institutions. All the facilities are available for the government institutions, so the quality improvement program becomes very well implemented in the government sector. But when the 45% deliveries take place in private sector, and when the maternal mortality ratio and the neonatal mortality rate and also the stillbirth rate, when we want to reduce it still further, there is definitely requirement of the private sector to be included in the quality initiative. So although at the national level maternal mortality ratio is 113, state of Maharashtra is doing well, and our maternal mortality ratio at present is 46 per 1 lakh live delivery, like 1 lakh live births. So we want to reduce it still further. We have achieved SDG goal, but then to reduce it further, we thought that the government and the private, if both the institutions implement the quality initiative, this will give a good coverage for the antenatal care. The quality of care given to the antenatal mothers also during intranatal period and the postnatal period, it will help to reduce the maternal mortality and the neonatal mortality. And therefore we thought that we will work together and we can go ahead for reducing the maternal mortality ratio, our goal still further.
Thank you, Dr. Patil. I think, this really dovetailed very well with Merck for Mothers' vision to end preventable maternal mortality. And despite Maharashtra doing so good as far as MMR rate is concerned, the government still is not contented with the current MMR, is working hard to save every single preventable life. And that's really what our motto is, and we want to do this worldwide. So I would be really hoping that this would be a global example of how we can work together to ensure standardized quality of care across the public and the private sector. And so my second question is to Dr. Nandita. Dr. Nandita Palshetkar was the president of FOXI, the Federation of OBGYNs in India last year, when this partnership was forged. And so what would you say has been FOXI's role in Manyata and in LaQshya-Manyata? Dr. Nandita.
After so many webinars, you still forget to unmute. Thank you, Pompey. Thank you very much for inviting me here and Bulbul and the WHO. I think it's very important for people to understand what is FOXI also. You know, FOXI is a professional organization of gynecologists and obstetricians, nearly 40,000. We are 40,000 in number, and we are spread across 253 cities all over India. And it's one of the organizations which is very actively working towards women's health. In fact, if I may take the credit, I think quality was a very fuzzy word, which we actually codified into 16 standards, Pompey. And, FOXI, along with its partners like Japaigo, like MSD for Mothers, and the others, actually created quality standards which could be assessed, which could be, achieved. So I think that's something that FOXI has really achieved, and I'm really very happy about it. And you can put it in the Make in India spirit, that it was all conceived here. Of course, we took the global standards of Japaigo and kind of altered them to our needs of the Indian women, what Indian women need. The second is, I think FOXI, along with MSD, I think MSD, when you all approached us, that there was a gap in standardization in the private facilities. Definitely all the private facilities, there is variation in quality. And I think it's one of the first professional organization to actually create a movement. It's a momentum of quality building which we've created in our country. It's the organization which has created this and got to all the private sector. And of course, our aim is to touch all of them, but I think it's a beginning, and we will be one of the organizations which has created a model which can be taken globally. I think that is fantastic. The other thing that I think is what is FOXI's role is, it's done self-regulation. This is totally voluntary. There's no danda. rule, or there is nothing that's hard and fast. You have to do it. And also it has brought the community together. Pompey, it has created champions who are working pro bono for women's healthcare. I think that is an amazing role which Foxy has played. And of course, I want to talk a little bit about what Dr. Archana Patil mentioned, the government of Maharashtra. I think I would really give full credit to the visionary role of Dr. Archana Patil. You know, somebody who realized that even though Maharashtra is such a fantastic state, it has aspirational districts, as pointed out by the Niti Aayog. Like, for example, Nandurbar, one of the very most difficult district to reach. Now, in these districts, we have managed to certify, along with LaQshya-Manyata, one facility, and 4 are being registered. See, this is delivering equity of care to everyone all over the country. And I think the government of Maharashtra, I really want to say thank you to you, because it has given us credibility. What Foxy was doing, it gives it credibility. And we're hoping we'll get more perks and incentives because the government joins, and all over the country they're happening. And what Foxy has done in Manyata, this is my last, I know we are on a very tight schedule, but we have registered more than 1,100 centers so far, and 800 have got the accreditation. 9,000 healthcare workers have been trained so far, and more than 3 lakh deliveries. That's in for everybody else, 300,000 deliveries have occurred in these quality care places. And remember one thing, I must tell you that people have appreciated this, and it's really, I'm very, very proud of being in Foxy, an organization which has been at the helm of affairs and has worked with fantastic people like Pompey. I think, Pompey, you're the driving force, and Bulbul, amazing, with all your teams, and Reba Shanwick and everybody, Echo, and all the other partners which Suranjin mentioned. I think it's been a fantastic experience. So we are happy that Foxy is in the forefront with all you guys, and we are caring for the women we care about. So we for 3, making Indian women safer, stronger, and smarter. That is our motto.
Thank you, Dr. Nandita. So it's in fact true that collaboration is the heart of the initial success that we have achieved, and very much in line with our Prime Minister's saying of being self-reliant, Atmanirbhar Bharat, which has been the new motto. We want to be self-reliant as far as Manyata and quality improvement goes. And hence, going forward, JPIGO is now transitioning the program, the technical knowledge through technical assistance to the micro entrepreneurs who are taking up quality improvement. And so, Dr. Bulbul Sood, as country director of JPIGO, you have been very, very instrumental in designing and kickstarting this program itself. The program that was customized to improve quality in the private sector. So we want to hear from you briefly about what your experience has been and what's your vision for the future. Dr. Sood?
Muted, you're muted.
Thank you very much, Pompey. So this was truly a Made in India program. And as Nandita said, when we started, and JPIGO has been working in the public sector, but there were no quality improvement program in the private sector. We, in fact, also had modified the safe childbirth checklist for the India context. And the first thing we did was to bring all the partners together, and we realized Foxy is the major partner, but also the state governments as well as the national government. And based on the best practices, we developed those 16 standards that Nandita mentioned. When those standards were tested in the private sector facilities, the Foxian realized that, yes, there's a lot to be done. And as she said, it kind of gave impetus to having quality improvement brought in the private sector. JPIGO also worked to ensure that we develop a working model for private sector, because what works in the public sector doesn't work in the private sector. And so we developed what we call as competency-based training, which was low dose, high frequency. And also from our experience of working in other programs in other countries, we brought in, a team-based approach. Drills were introduced. The providers found that the nursing staff, especially in these private facilities, which were led by mostly the Foxians, they needed a lot of input. And once they started, so in some ways, the quality became a motto for each of the participating private sector facilities. And when they started seeing the impact of it in terms of reducing the maternal mortality, they would be able to manage the newborn survival was much better. The other complications were reducing, that more and more people joined. And today I'm glad to say that this is already program is running in 6 states, and more than 3-4 states are already ready to take it forward. So again, this has been an initiative which has been led by Foxy, led by the state government. The LaQshya-Manyata gave opportunity to actually talk about equity, that it has to be the same standard which has to be followed both in the public sector as well as private sector, what we call as frill or no frill, but all women deserve same quality care. And this is what is the vision of the Government of India, the Foxians, and all the partners who have been working on it, including the MSD. Thanks.
Thank you, Dr. Sood. So indeed, quality is the third pillar and the most important pillar of universal health coverage, besides affordability and accessibility. And so we are hoping that LaQshya-Manyata, and together with the government, the private sector will be able to step up, self-regulate to meet the standards and provide the care the women really deserve. So Dr. Archana, I really wanted to understand from you, what is the vision of Government of Maharashtra? What is your vision of reaching out to those people in the far-flung areas like Nandurbar and the remote districts of Maharashtra, and those women who actually need quality care, those women who are dying because of preventable diseases? And what's really your vision? What more needs to be done to ensure that we are indeed able to accelerate decline in maternal mortality together?
Yes. So there are now two aspects. One important is that when we talk about the urban area from state of Maharashtra, the about 50% population at present is urban population. So when we talk about the urban population, the private sector is very strong in this corporation area, and therefore this our initiative of LaQshya-Manyata along with Foxy, it will improve our quality in these areas. And another scenario, as you mentioned, the Nandurbar district, very difficult district. Likewise, we have also a Gadchiroli district. So there, the scenario and the situation is totally different. So there, the government sector is strong, but still the problem is reaching to the areas which are really inaccessible, which are really very remote, and one cannot imagine the inaccessibility in that area. So to reaching that area and to get the trained manpower, that is the main aspect for us. So in Nandurbar district, like we have our initiative, although the government is trying to have a capacity building of our all health institutions, improve the quality. In the private sector also, similarly, we are trying to use this model and we are trying to improve. So if we see at present in our LaQshya-Manyata, about 200 facilities, they have registered with us. Their assessment is also going on. Initially, we had assessment done of about 8 to 10 facilities, but during the COVID situation, that process was little bit hampered. But now we have started the virtual assessment also. And when we see a collaboration, So it is at various levels, because initially when we develop the standard, so for that developing standard and improving those standards also, the government and private sector work together. When we come to the training part, the infrastructure and the trained staff and the trainers from government along with private, they are working together and they are training the trainees from various institutions we have registered for the Lakshya-Manyata. Similarly, when we talk about the monitoring, because the program needs to be monitored, and the various committees that we have formed at the state level, so it is a multifaceted monitoring committee. So with the help of them, we are trying to monitor that program so that the program will be implemented very well. The women will get a good care during their antenatal period, also intranatal period, and immediately postnatal period. And the maternal mortality ratio of 46, we can come still further, and we can give the best quality services in all these institutions. So we are trying to hope to the because even in the corporation and urban area, although we say that the urban area, their elite population is there, but when we talk about the slums in that area, so in that area also we have to provide services. And similarly in the tribal and very difficult and the remote areas also, we have to provide the services. So along with the private sector, I hope we can reach to majority of the people, and we will try to improve our maternal and child health services.
Thank you, Dr. Patil. So indeed, it is a systems approach that is being adopted in Maharashtra together with all the other uh, uh, funding partners who are supporting the state. There are other funders who are supporting digitization, community health workers, and at the core of it, we're trying to understand the reasons for maternal mortality. So maternal reviews, the maternal death reviews have been an integral part of the approach that we've adopted towards strengthening of the private sector facilities. And Dr. Nandita has been very, very active in these maternal death reviews, and we've seen the cause of death transitioning from PPH to eclampsia as the #1 killer of mothers in the state. With that, we'd like to address, really the QED, the third pillar of QED, which is dignity. And Dr. Nandita has been in the forefront of propagating for respectful maternal care across the sectors, and in particular across all the small and big private sectors. So Dr. Nandita, tell us a bit about respectful maternal care and how we can achieve it.
Thank you, Pompey. I think this is a very, very important pillar. And as I've been saying everywhere, it's not only quality that matters, even RMC or respectful maternal care is very, very important. And I think, we realize the importance of it by including it as one of the standards of care in Manyata. So, leaving it aside, if you look at today's medicine, it is very medicalized. It's centered around the doctor, not around the patient. And what is important over there is that we need to think about the patient, her dignity, her privacy, and what she wants. I think we've forgotten the simple question of what do you want? What does a patient want? Like she would like, maybe not her husband during her labor. She may want her friend or her sister or her mother to be there during labor. So all these are very simple things. And believe me, when we have talked to the Manyata registered centers who have been accredited, the most appreciative standard which they have all appreciated is respectful maternal care, because what has happened is it has changed. It's like a behavioral therapy for the doctor, for the staff, for everybody, because everybody behaves, they're sensitive, they're sensitive to the needs, they're polite, they want to help out, and they want to make, you see, birthing is one of the most beautiful instances in a woman's life, and that's what we have to do for her. So I think this particular standard has actually changed everybody's attitude towards it. And as WHO has also identified it as very, very important dignity, because a lot of people, even I, would not go to a place where I'm not respected. want that respect. It's not about anything else. It's just about self-respect, and every woman should be given that. So I think Foxy in its own way has sensitized its doctors, and we are sensitizing the entire Foxians about respectful maternal care, about not to, mistreatment of the women. And I think Lakshya also has some beautiful set in standards which they need to implement. And I think the best thing is the feedback from the patients. I think that's a very, very important aspect of Manyata, which I like, that there is a feedback from the patients who will tell us about how the facility is, and so we can make changes. So Pompey, I think respectful maternal care not only helps the woman, but also helps the doctor. From a doctor's point of view, I'm telling you, the patient has a fantastic experience at yourself, at your hospital. She's going to tell 10 other people, and more people will come and deliver with you. So I think it works both ways. I can
Thank you,
go
Dr.
talking and
Nandita.
stopping now.
Thank you, Dr. Nandita. So true, I think Manyata is probably the program that touches upon, is trying to strengthen all the aspects of the QED movement, the QED global movement. And we're trying to gather evidence to contribute to the global body of evidence around quality improvement itself. How can quality be improved? How can quality be sustained? How can we create a market for quality so that there is longitudinal involvement of the facilities and there is a quality culture, so that it is not a one-stop thing. It doesn't stop at accreditation. It's an ongoing process. The quality journey is an ongoing process. So Dr. Sood, can you tell us a little bit about what evidence you are trying to gather through scaling up of Manyata, as well as how do you think all of these efforts can help make a more resilient health system for India?
Thank you, Pompey. I think COVID pandemic gave us an opportunity to first relook at how we were implementing this program on ground. And as you know, once the pandemic started, we could not go to the facilities, and we used this opportunity to use a digital platform. And since Manyata already had a collaboration with Echo Platform, we came up with a lean model to train to the Manyata facilities, and also provide the monitoring and supportive vision support, as well as the assurance part. The quality assurance was also done digitally. So that was one thing which happened, that now we have come up with a lean model to implement this program, so that now it can be, as you are saying, we are thinking of having this pan-India, and more and more facilities once joins in this program, they would need to quickly have the standards achieved in these places. We have also been looking at generating evidence to say what is working, what is not working, since I think it won't be wrong to say that this is the largest private sector program so far working anywhere in the world, and other low and middle income countries are looking at our experience. So we have collaborated with Ariani Lab, and they would be looking at both at the macro level and the micro level of quality improvement, and what is the impact on both the providers' competencies as well as the outcome of this program. The third thing that we have been looking at is also how to have this particular model scalable and sustainable. And so to come up with a business model to have ensure that this can be a self-running program beyond once the donor moves out. And I'm happy to say that already there's a lot of interest which has been generated. A business model has been tested, and we'll know exactly what works, what doesn't work, how we have to modify it. But most important, as Nandita said, that the dignity has come back into providing quality care to the women. As the Manyata logo says, don't forget moms. I think the respectful maternal care, having a choice of companion is now becoming a way of life, both in the public sector as well as private sector in the country. Thanks.
Thank you, Dr. Sood. So besides the work that is happening in 6 states, there is also an impact bond route that is being followed to scale Manyata along with facility standards that the country has adopted, which are the NABS standards, which is being done in Rajasthan. And there, despite a very active support from implementing partners, a big cohort of facilities failed to clear a round on maternal standards. That speaks to the quality improvement that is needed in the private sector, and it speaks to the need for maternal health standards to complement facility standards. So I would really like to thank Government of Maharashtra again for taking the initiative of combining LaQshya and Manyata and setting one country, one standard example, which we hope will be able to gather evidence around to contribute towards global evidence. Thank you, WHO, for this great opportunity. Over to you, Benedict.
Thank you very much, Pompey, and all our panelists for this comment and this insight. We've had a lot of questions in the chat box while you were speaking and a lot of interest. So we're not going to be able to answer them all, but I'm starting with a few that were on timeline. I see that several people on YouTube have answered. So timeline for certification is between 3 to 9 months. We have quite a lot of questions about access and the kind of women who have access to this facility. I've seen that Professor Moni Islam has answered this. I see that we have some answer already. Does one of the panelists want to answer? Or Suranjin, do you want to talk about what is the socioeconomic status of the women who have access to the facilities?
Benedict, the government is taking care of the people who are socioeconomically backward, and Manyata is taking care of the slightly better, those who are paying for their services. So there was a question saying that nobody's taking care of the, the poor patients if we are only going to focus on the private sector. But the government has really put all its machinery into the public sector, and we needed to work on the private sector. So Manyata has come to bridge this gap which was existing. So all the socioeconomic statuses of the women are being covered either by the government or by the private sector.
Thank you. And to follow up on this, on the cost of service, there's a few questions on how is this financed. So who pays for the certification at the facility, and then who pays for the service? And if you can answer this, there is a few answers already in the chat box. Sorry, but if you could answer this, that would be great. So who pays for certification? And then who pays for the actual services when you want to access it?
So I can start it. This is when we initially started, it was for the proof of concept, the participating facilities were not paying anything. But in the next phase, when we started scaling it up, we said that this has to be a sustainable program. So today, the participating facilities at the time of registration pay some amount, and then at the time of certification, they pay amount. So this is not a free program. This is a program where the facilities are paying. Again, it depends on if it is a larger facilities, they pay a little more than those who are having less beds.
Mm-hmm. There is a question about the demand side, and I've seen already that the answers say that there is not much work done on that side yet. It's mostly on supply for now. But do you have any plan in the future to combine it with a demand side incentive for pregnant women, like vouchers to increase access to low-income clients?
I didn't understand.
There's a question about the demand side of the program, or whether you are planning to have a demand, to have an incentive for demand for pregnant women. So they will have, for example, a voucher to access the services.
So I can take that question. This is Pompey. The Niti Aayog, which is the National Institute for Transformation of India, is already considering quality improvement initiatives to be mainstreamed in India. And for maternal health standards, they have recognized that the private sector also needs these standards like Manyata, and therefore there is a strong push for UHC schemes, and wherever government is strategically engaging with the private sector to adopt standards of care. So National Health Policy has in 2017 stated that they want to strategically engage with the private sector, and therefore the private sector has to step up and align with the standards that the government is actually putting in place. And Dr. Nandita can also talk to this.
Yeah, I think there are certain facilities in tertiary care hospitals, which the government does not want to create the infrastructure. They're utilizing these facilities, and they have checked out whether their quality standards are good, and then they outsource the work to these facilities. So strategic purchase, as you said, is what the government is doing. So that is some kind of vouchers which they give their patients to go into these high-end facilities for tertiary kind of, help or surgeries or treatment.
Thank you. A question on the private facility involved in the program and the selection criteria to select them. There is a short answers on the kind of criteria you had to select them, but can you elaborate a bit more?
See, at the moment, we've opened it to all private sectors, in the 6 states that we have. So anybody who's delivering, conducting deliveries is allowed to register for the present certification. So there is no restriction as such.
Thank you. And of course, you got a lot of questions on the scale up from the initiative. A lot of people complimenting on Manyata and the way it's set up, but how are you planning to scale it up to more private providers and facilities?
My take on it is very different from what Pompey will talk about the scale up of the business model. But I think behavioral therapy for the gynecologists is very important. That quality exists, quality is a must, and quality has to be there. It has to go into their brains, So we need to actually sensitize our doctors about quality is a essential commodity. So that is, I think we should work in that way from the human angle. And Pompey will definitely, and Bulbul will definitely talk about the business model, how they can scale it up. But this is also very, very important, I feel.
Pompey and Dr. Sood, do you want to add to this?
Yeah, thanks, Dr. Nandita. So to the core of scale is digitization of the entire process. So what components of the program need to be digitized, lower transaction costs, and VCR exist in the micro entrepreneurs. And I'm very happy to say that about 8 to 10 micro entrepreneurs or training centers that were run by the OBGYNs of India have come forward to take on Manyata Quality Improvement Program. This again is a huge big step towards sustainability and self-reliance that our Prime Minister talks about.
And just to add to what Pompey just said, that already the skill enhancement centers are working efficiently, and we are working with the PwC to come up with a business model, how to maintain these standards at these facilities, and to ensure that more and more facilities could enroll. I think in next 6 months, we would be able to tell you more about the strength and weaknesses of different models that we are working on. And of course, definitely how the digital technology, how is going to be used in training and mentoring, and how is it working and how effective it is, we will be able to share more insight again, I would say in next 6 to 9 months.
Benedict, can I interrupt here? I think the government has done a great job in getting a lot of facilities for LaQshya. So maybe Dr. Archana Patel can actually give us insight how we can get more, people to do it.
Yeah, Dr. Archana.
Absolutely. Yeah, absolutely right. But what I say that the business model, yes, it is required. But when it is a joint certification, when
Yeah.
we give a certification to a institute, it is a joined by the FOXY president and also the government head, and therefore it gives a good weightage to the facility also, because the how you look at the facility when it is accredited by government, the perspective of the people also changes, and therefore the in addition to business model, this is very beneficial to the private sector also. That is what I feel. And the when we talk about the how we can scale it up, we had various workshops with the Foxy, with their various societies, and we tried to inculcate in them that the, as Nandita said, that it has to go in their brain that the quality is important. But now, yes, they have also started talking, and with our various efforts from the various at the district level, also at the state level, we have common workshops and we have common webinars in which we try to insist this aspect of the quality, and we are hoping that other people also will join this initiative.
Thank you, Dr. Patil. I see that actually there are comments on the chat box on how the government endorsement really adds value to the certification for the facilities. Suranjin, I see you answering very fast in the chat box, and you did have quite a lot of added comments about scale up. Do you want to take the floor and answer?
With regard to scale up, we are in a process of actually coming up with a plan for it. MSD for Mothers is actually, is working on it. But immediately what we want to say is that we are actively looking, like for the state of Maharashtra, we are doing two things. One is actively talking to obstetricians, like what Dr. Nandita said, through our champions there, to see how they can join the movement. And the second one, we are actually working with the governments in certain districts to see how we can get a kind of a district-wide push and a district-wide kind of a movement to see that the whole district, all the private sector in the district, come in. And we are starting this in the aspiration. So these are our two pushes to see how we could, get everybody to come in, to join. But the dream or the vision is to see how we could, spread quality to a critical number of at least 60 to 80% of all facilities, certified in a particular geography.
Thank you. And finally, I think this will be our last set of our last question and set of answers about the assessors and how they're set up, how they're chosen, and how they work. Suranjin, you have been answering this a little bit. Do you want to take this for the participants?
So the assessors initially, since these were clinical standards and not facility standards, we felt that only another obstetrician who really understands context should assess them. So that's the reason why we used peer assessors. So we usually, in the initial days, we used assessors from other districts to come in and do it. And as Nandita mentioned, this was a movement where people actually pro bono actually came in to assess other facilities. It was like a kind of a sisterhood thing where people actually work together to look at it, to learn from each other, and to take this further. With the Government of Maharashtra, with the peer assessor, we've added in a government assessor. The government assessor are assessors who are assessing the public health sectors for LaQshya, who are also clinicians or public health managers. So these are the assessors at this moment.
Thank you very, very much. I would like to thank our distinguished panelists today who took the time to answer all your questions, or a lot of your questions, not all of them, and to thank the team from the Manyata program for their presentation. And we'll wrap up today. This is recorded. We're going to send you a link to the recording and all the presentations. You will also see on your screen that we invite you to continue the discussion on our committee of practice. So all your question and answer will be posted there. And the one that we did not have time to answer, we also put there with a chance to further the conversation. We also invite you to continue joining this series of webinars. We're going to have a lot of content on engaging the private sector, check out the Private Sector Engagement Initiative. You have the link on your screen as well. Thank you again, everybody on the call today for your time and for asking and answering the question. And I'm now closing the discussion. Thank you very much. Thank you, Dr. Patil, Dr. Sood, Dr. Pashetkar, Pompi Sridhar, and Suranjin for your contribution. Have an excellent day.
Thank you very much. Thank you very much.
Thank you, Benny. Thank you very much.
Thanks, everyone.
Thank you, Dr. Patil.